Good morning. I'm Dr. Steve Stites, Chief Medical Officer here at the University of Kansas Health System. Welcome back to Open Mics with Dr. Stites. I'm here with Dr. Dana Hawkinson, the Health System's Director of Infection Prevention and Control. Doc Hawk, we're happy to have you always. And today we are really happy to welcome back vaccine expert Dr. Greg Polin. He is the Director of the Vaccine Research Group at Mayo Clinic, the Editor-in-Chief of the medical journal Vaccine, a friend of the program and a frequent flyer with us. And for today only, he's our birthday boy. Happy birthday, Dr. Polin. I've got a gift for you. I'm not going to sing to you.
Thank you. You know, I've been told that when I sing, it brings tears to the eyes of music lovers.
Yes, well, yes, my failure to karaoke I was not a featured performer, let's say that. And what better gift than brand new vaccines? For the first time ever, older adults can get vaccinated against RSV, or Respiratory Syncytial Virus. Don't try and say that too quickly, it'll come out funny. 2 new shots are coming out this fall. One is from Pfizer and another from GSK. They're both FDA approved and CDC recommended for adults 60 years and older. Generally speaking, most RSV cases are akin to a cold, and patients recover on their own. But infants, older adults, that's probably like me, and people with certain conditions with asthma or diabetes, cystic fibrosis, transplant, cancer, are more likely to need hospital-level care. Dr. Polin, the effort to make an RSV vaccine has gone on for years because those of us who practice in this space, and Hawkeye clearly practices in this space, it's a respiratory problem when it does happen and bring people to hospitalization usually, so the lung guys get involved. We know it's messy. But how come it took so long to get one of these vaccines for RSV? And tell us how important they are.
Well, yeah, in terms of how important it is, you're exactly right. For most cases, this is a relatively mild sort of cold-like phenomena. But when you think about in the U.S. with adults over the age of 60, 65, you're talking about 60,000 to 120,000 adults who get hospitalized and about 6,000 to 10,000 who die as a result of this infection. So it is absolutely something worth preventing. And those attempts started way back in the 60s. In fact, in 1966, there were 4 clinical trials of an inactivated, what they now recognize was a post-fusion vaccine. We can come back to what that means in a minute. But, and this was for children. The consequence is once they got exposed to the RSV virus, about 80% of them got sicker than if they had never had the vaccine, and a handful died as a result of it, something called antibody-mediated enhanced disease. So that really stifled any RSV vaccine development for well over half a century. So this is really a game changer in terms of understanding the structure and function of this virus. And the important thing is that they found out that this one particular protein called the F, or fusion protein, has to be in the pre-fusion configuration. And when they did that, the vaccine worked and worked beautifully.
Okay, so you're going to have to tell us what this pre- and post-fusion stuff is, because I think it sounds like a nuclear reactor or something.
Yeah. These are just pieces of the virus, this F protein or fusion protein, that binds to a cell when it's trying to infect the cell. So once it binds, it's in a different configuration, sort of like a flower being open or a flower being closed. We want it in that pre-fusion, the flower open configuration, rather than the flower closed or post-fusion. And as I say, from a structure function point of view, that made all of the difference in terms of efficacy and in preventing those kinds of complications.
So why did people get really sick or die when it was one side of this and then the pre-fusion side that didn't happen? Why the difference, do you think?
The reason is that they would develop antibody with this old vaccine, but the antibody was not neutralizing antibody. So it would coat the virus, but not stop the virus at all from entering into the cell and making people sick. And yet the immune system thought it had neutralized the virus. So sort of a bad situation there.
Yeah, that would be a bad situation.
And let me just stress,
please,
that is not happening with these new vaccines.
Yeah, I was going to ask you that. Next, my follow-up question was, why is it not happening with the new ones? You mentioned is pre-fusions and post-fusions, so it's kind of the flower is still closed, and so you're coating the flower, and now the immune system still says, I got to go attack it. Is that it?
That's right. So the antibody that's made to this pre-fusion or open flower configuration is getting to the neutralization sites and neutralizing the virus. So it cannot bind or fuse with our own cellular membranes, therefore can't enter the cell, therefore can't make us sick.
That sounds really good, much like a pretty significant step forward in one of those miracles of science. Is this one of those kind of messenger RNA vaccine, or how is this one made? I mean, we've talked so much about mRNA vaccines, but I think this one's different.
This is different. You're right, Steve. This is not an mRNA vaccine, although Moderna is working on one. But the GSK and the Pfizer vaccines are what are called inactivated protein subunit vaccines, much like hepatitis B, HPV, influenza, a number of other vaccines that we get. So this is a really well understood, well known, and for the most part, safe way of making a vaccine.
And how effective is this vaccine? I remember when we talked about influenza, we said, yeah, it's about 50% effective. When we talked about COVID, like, yeah, we're 90% effective. Where does RSV land in that spectrum?
So one thing to remember when you see the numbers about efficacy, and this is something that I think a lot of physicians and for sure the lay public did not understand, is that the efficacy of the vaccine is highest against the more severe outcomes. So it's very good in preventing severe disease, on the order of 85 to 95%. When you start getting to lesser degrees, including just, well, I have symptoms of RSV infection, you're probably talking about 65 to 75% efficacy. In terms of comparing them, it's really difficult to do, and if I get too deep into this, just let me know.
No, you're doing great.
There were some odd things about the clinical trials. During the 2 years so far that the trials were conducted in, the first season started late, the second season started early. It was while a large number of Americans were still distancing and wearing a mask. It happened to be an RSV B year rather than an RSV A year, and A is much more prevalent, much more common. So those were kind of odd, goofy things. Nonetheless, they showed this high efficacy in the trial. So who knows, as we actually get this into clinical practice, we may in fact see that the efficacy is even a little higher than what was shown in the clinical trials. One other proviso is that they did not have a lot of people in the trial over the age of 80. So we don't know a lot about the efficacy of the vaccine in people over the age of 80. And they, of course, are the ones, the older you get, the more likely you have complications or severe disease. So that's an important proviso also.
Yeah, that's a really big deal. Well, look, we're going to come back to you in just a moment. I do want to say once again, happy birthday. You look like you're in your 30s. It's impressive. We need to bottle that tonic and send that around. So, hey, we talked with someone who knows how bad RSV can be. 54-year-old Mitzi Lawrence ended up in the hospital when breathing became incredibly difficult. She says it was like an elephant constantly standing on her chest. I think that sounds really awful.
I thought I just kind of had a cold. But then I could feel my chest was tightening, and it continued to tighten. Just the smallest of steps to go to the restroom, to go to the kitchen to get something to drink. I was panting, and like for small children, it can continue to affect them for the rest of their lives. And who knows what it will do to me for the rest of my life as well. I'd never been on an inhaler before. They said you need to have this to help you to keep your airways opened up. it's a doozy for sure. It's a doozy of a sickness, and you definitely don't want it. I mean, definitely don't want it. I like to breathe.
That's not an uncommon story, and I see a lot of patients with RSV who end up being hospitalized because of the transplant patients, the cystic fibrosis patients, and they really can get in severe trouble, and some of them do die. In Mitzi's case, RSV triggered pneumonia. Her oxygen saturations dropped into the low 80s. Remember, it should be around 96, 97, 98, 100. And when you get into that low 80s, you're going to be breathing hard and fast, and oftentimes you're going to have to be put on life support and sometimes even onto ventilators and things like that. RSV probably hit her harder because her immune system was still recovering from a bone marrow transplant. And again, patients like this are really susceptible. Doc Hawk, would you say that Mitzi's case is more severe than most?
Yeah, I mean, I think if we talk about RSV infection in general, just as we heard Dr. Poland say, RSV can cause symptoms from a common cold, which is not very intense, not very significant, but for certain people, especially those that could be very older age or younger age, but also those that are immunosuppressed, you can have significant severe disease, and I think this was one of those more severe cases for sure.
It sure sounds like it.
Yeah.
When the other thing we know that in the lung transplant population, when they have RSV, we generally bring them in and treat them in the hospital for it with a drug called inhaled ribavirin, which is a different study, different program, different show sometime. But because it can be linked, RSV can be linked to chronic rejection, and you don't want that post-transplant for sure. So talk to me, Hawkeye, about the safety of these new RSV vaccines. And I think Dr. Poland hit this as well.
Yeah.
Now, there's a little difference between some of the outcomes in both the Pfizer and the GlaxoSmithKline or GSK trials. Talk to us a little bit about that.
Yeah, I mean, I think, again, an older platform, so we know about this. We know the mRNA technology for the COVID vaccines was relatively new, but had been studied for decades. This kind of platform, this kind of technology has been used in other vaccines, just we heard as Dr. Poland talk about. We know they are very safe. Again, the most common reactions continue to be things like where the vaccine is injected at, those site reactions, maybe a little bit of pain, redness. There were a couple instances of things like Guillain-Barré, which is a neuropathic issue that can happen after infection or vaccines. But we still need to study them more. But overall, the safety and efficacy of these vaccines continue to be very good. And of course, once the vaccines are rolled out, they will continue to monitor actively and passively for any signals of any new complications that may arise.
Okay, so I'm going to ask you guys both this question. So we'll talk a little bit about the age indication. So I'm over the age of 20.
Yeah.
Okay, 30. Maybe 40, 50, 60. We'll stop there. So should say, cool, handsome, goofy, white guy over 60 be getting the RSV vaccine this fall? What do you think, guys?
Yeah.
Dr. Poland?
You're asking, should you get it?
Yes, sir. I am over 60. I confess to that.
Yeah. Well, what the ACIP did is say, well, we're going to use. Oops, did I lose you?
Nope, we got you.
Okay, what the ACIP said is that we're going to use shared clinical decision making, meaning you and your physician would talk about the risks and benefits of the vaccine and the particular risks that you face. But in general, for people over the age of 60, that's when we start seeing the hospitalizations. That's when we start seeing the complications, the bronchitis and tracheobronchitis and the pneumonia that happens. So in general, unless there were some contraindication or some other reason not to give it, I would be a fan of saying this is important to get.
Yeah.
Yeah. I
Okay.
think so.
All right. So I guess I'm getting on the program this fall. Here we go. All right. Now, here's the next question. We're looking at 3 different shots this fall. First of all, can we spend one moment talking about the COVID vaccination? And we're switching gears just a little bit, talk about COVID. Dr. Poland, why is it delayed? What's going on? It got held back a little bit.
I wish we knew why this has gotten to be a little slower of a process. We're just starting a surge of EG5 and EG5.1, which didn't quite come out of nowhere, but we've been monitoring this since June, July, and it has become now the predominant variant of interest. And the vaccine is going to be made against a slightly different variant called XBB 1.5. Now these come, while they're both distant cousins, if you will, of Omicron, they come from slightly different lines. So what that will mean in terms of efficacy is yet to be determined, but I'm sure it will be efficacious against the more severe manifestations of disease. But you're right, Steve, the ideal thing would be those vaccines would become available now in early September. Instead, it looks like it's going to be maybe mid to end of September into early October before we have these.
So what's the sequence here, guys? Which one should somebody get first? RSV, influenza? I think we have RSV vaccines here in Kansas City now, and we don't have influenza vaccines yet, and we don't have the COVID. So should I just go and get the RSV? What's the right sequence here?
Yeah, I would say go get the RSV vaccine, because at least at this point, the data suggests that it's effective over 2 respiratory viral seasons. So it's not like it's going to wear down and you wouldn't be covered. So I'd get RSV. The next one that will be available will be flu vaccine, and then the one after that will be COVID. However, let me stress, we don't have any data to suggest that there's a problem getting them at the same time. But a lot of people would prefer to separate them, particularly with a new vaccine, so that if there were any kind of side effect, you could make a reasonable guess as to which one may have caused that side effect. You wouldn't be able to do that, of course, if you got all 3 at once. But either way is acceptable.
I think that one of the things we mentioned is the shared decision-making, which means the physician and the patient have to sit down together and go through the information of the provider and the patient. And I think for people who are over the age of, they have certain comorbid conditions, it's clear. You have cancer, bone marrow transplants, you have high-risk diseases. I think the question is some of these folks with mild asthma, airway disease, et cetera, some folks like that really get into severe trouble with RSV, and I think it would be really important to go ahead and get that vaccine in that situation. So guys, are we anywhere close to getting the 2-in-1 or 3-in-1 where we can kind of mix all these together, Hawk?
I don't know how close we are. That's a relative term. We know that these viral vaccines are being investigated, of course, most prominently on the mRNA platforms. But we know those questions are being asked, those things are being looked at. It's just a matter, I think, again, going back to resources and where is the money and the resources coming from. Certainly for that initial round of the COVID vaccines, we know how much resources were put into that from the U.S. government and private companies as well. They are looking at trying to get multiviral vaccines to do that. They are also looking at universal vaccines, so a universal vaccine against different kinds of SARS viruses, different kinds of influenza viruses. But again, these things take time and money, and it's really about those resources and being able to do those experiments.
Excellent. And by the way, you look so much better from that poison ivy. You are clearly in the recovery phase. Can we get a vaccine against poison ivy? Come on, Dr. Plum, what are you doing in that vaccine research group out there?
There actually is a vaccine against poison ivy in clinical trials.
All right.
Awesome.
There we go.
Well, we'll sign up. Hawkeye's going to sign. I'll sign Hawkeye up just to be sure. All right. If you have questions about RSV, COVID, or vaccines in general, or the poison ivy vaccine, ask them now. Use the chat on YouTube and Facebook, or tweet us or email us at the Medical News Network. And when I say tweet, of course, we really mean X. All right. Let's turn our attention to COVID. Hawkeye, the numbers are up at our health system. And they're also up nationally.
Yeah, so I think, just looking at our numbers, we had 7 active cases Monday. We've really held under 10 active cases for quite some time now, a couple months, which is a good thing. We noticed little trends moving up for a couple days and then back down for, again, the active cases. We also know that there has been those articles about increasing cases in the United States, increasing hospitalization. Certainly, I think the virus is circulating more out there. We are getting more cases diagnosed at home with home tests or here at the hospital. And then we've seen hospitalization numbers increase as well. So when you see the articles, they talk about it's been a 50% increase or a 30% increase in the hospitalization. But when you look at the active numbers, the actual numbers, the numbers numbers are quite small, which is a good thing. And I think that is related to, number one, prevention. People have a history of getting vaccinations, so getting protected against hospitalization and severe disease. Also, you get some protection. The data is back and forth. You get some protection on previous infection as well. But we also have those outpatient treatments with Paxlovid to help reduce your risk of hospitalization and severe disease. And really what we have seen is this disease now is becoming a disease of those who have risk factors, so age, immunocompromised, other chronic conditions. And so we are really dealing with a smaller subset of the population, but we need to make sure that we are vigilant in continuing the message of prevention with vaccination, but also early testing and early treatment as well.
Dr. Pullen, how concerned, how nervous are you about this fall around COVID? I mean, there's the waning vaccines. The vaccine is not quite as effective. We don't have the new one out yet. People have gotten a little more lackadaisical and blah, blah, blah. Are you worried?
Yes, like Hawk said, I think this is now becoming a disease of people who have risk factors and people who have not been immunized or are not up to date on immunization. If you are immunized, if you're otherwise healthy, then you convert this infection into an annoyance for the most part, rather than something that is health or life threatening. So the key is to maintain your immunizations, get your boosters when they become available. As Hawk said, early testing with symptoms and treatment with an antiviral, if you're older or if you have risk factors, is key to maintaining your health and your quality of life.
Yeah. All right, so if you were, or Dr. Pullen, there's another question I want to ask you. You've talked, or we've heard a little bit about this long vax syndrome, and you and I were talking a little bit about some of the side effects around that at the beginning, or before the beginning of the program. You know, the journal Science reported on rare cases of people getting long-term COVID side effects similar to having long COVID. They appear to be pretty rare. Talk to us a little bit about that.
Yeah, this is a very interesting thing, Steve, and it will undoubtedly advance our knowledge of science. But what this appears to be are immunologic reactions that symptomatically look similar to long COVID. So it's being called, quote, long vax. People have seen, for example, autonomic dysnomias, for example, POTS. All kinds of symptomatology that it's a little hard right now to determine how frequent this is. It looks to be very rare when you look at a population level. The risk to an individual of developing something like this due to the vaccine is orders of magnitude smaller than the risk of developing those kinds of complications from the disease. And so the balance of risks and benefits decidedly remains in the get the vaccine camp.
Yeah, and I think that's a really important thing to stress. Have we seen this kind of long vax syndrome, so to speak, from other vaccines?
You know, certainly, for example, influenza vaccine, about 1 in a million or so develop Guillain-Barré syndrome. So absolutely, there are inflammatory and unusual types of side effects that occur in relation to vaccines. Fortunately, those are very, very rare. And let me just stress, Steve, they're so rare that multiple times my research group has decided to try to look in. We developed an area of medicine called adversomics. In other words, we're interested in the immune responses that are aberrant and cause side effects. They're so rare, we can't really study them. We don't have enough people who have those side effects to have enough statistical power to study them. You have to look at whole health networks or whole nations in order to get enough cases to understand what's going on.
Yeah, you know, that's an interesting thing, and I think it's probably good news that they are so rare. Bad news, you can't study it, but good news that they're so rare that you can't study it. I mean, it's one of those kind of good news, bad news things, I guess. And just again, to stress for our audience, COVID's real. COVID patients are still dying. There's very, very, very rarely a death directly linked to COVID vaccination, which somebody hasn't had COVID. I mean, that is just, I can't tell you how rare that is. But death from COVID, that is still not rare, unfortunately.
Yeah.
All right, I bet you there's a lot of questions out there. We're going to turn to Alexis Del Cid in Studio B to help us hear those questions and get some answers.
We have some fantastic questions, and actually the first question is about monkeypox. So we're hoping that Doc Hawk can address this one. It's from our viewer Yen Liang, this is what Yen writes. There's a variant of the monkeypox virus called EG5. I'd like to ask Dr. Hawkinson about the current situation, whether it's necessary to actively get vaccinated, and how effective is the vaccine, and could it turn out that EG5 turns into a pandemic? Could you clarify any of that, specifically about EG5?
Yeah, it sounds to me, and I'll have Dr. Stites and Dr. Poland weigh in too, it sounds to me like this is maybe a little bit of confusion with the new SARS-CoV-2 variant, or the current predominant variant, which is that EG5, the Eris, a variant of the Omicron sublineage, as we've heard. So I think that's what maybe the discrepancy is there. Certainly she can write back for a little bit of clarification. But as far as monkeypox and vaccination, we know that we do have 2 vaccines available. One is a live and one is an attenuated vaccine that is recommended for especially people at highest risk of developing monkeypox. Again, this was originally developed as a smallpox vaccine. It does provide very good protection against clinical disease, but we've also seen some people that have gotten the vaccine and had certainly more milder cases of monkeypox disease as well, or Mpox. I think we need to be calling it Mpox. But certainly talk with your primary care provider, talk with your physicians about, do you think it would be recommended for you to get the Mpox vaccine? And I'll certainly look for Dr. Poland or Dr. Stites.
Oh, I got nothing on Mpox, but you guys.
Hawk is exactly right. The person who wrote the question is confusing the EG5 variant of COVID with Mpox. And everything Hawk said is exactly right. You can't stump Hawk. Maybe that's what we should do one day, is have a stump
let's
doctor.
do this. I'm in that program right there. That's going to be it. Show me the hawk. What do we call that? What do we show me the science? Show me the hawk.
As long as it's not working outdoors in the weeds, that's fine.
Alexis.
We received an excellent email from a viewer named Jason Cohen. It was very detailed. He had several COVID questions, so we're going to break down 2 of them. One of his questions is, if someone is younger than 50 without comorbidities and has immunity either from a vaccine or a previous infection, do they no longer have to worry about the current variants in terms of putting them in the hospital or causing long COVID?
Well, I think that's going to be incorrect, because you can get COVID, you can get long COVID, guys, from any one of the infections you get, and severity doesn't really necessarily mean you will or will not get long COVID. Correct, Dr. Poland?
So, bingo, Dr. Stites is exactly right. That is a key message that our listeners need to hear. The issue for people who are otherwise have underlying good health and who have been immunized is not that they're going to end up in the hospital or die. It'll be the disruption in their lives, right? I can't go to work, I can't go to school, I was supposed to go to a family wedding, that sort of thing. But the real concern is complications and long COVID. We don't have a precise estimate by demographics of how often that happens, but the numbers are somewhere around 10% plus who develop longer term symptomatology. There have been some interesting studies showing chronicity of the virus harbored in skull bone marrow, causing long-term neurologic symptomatology. So I think it's a real misnomer to say, well, I'm healthy, I've gotten all my vaccines, I don't need to take any precautions, I'm home free. That's just not the case. You're home free against death and hospitalization, very likely, but not against these other issues.
Let's say it's been 2 years, guys, since I've had COVID.
Yeah.
Am I still going to be protected even against things like that, hospitalization and death? Let's say it's been 2 years and I haven't had a vaccine. Am I protected, or have I kind of lost some of that immunity?
Well, you're losing some of that immunity. Certainly the humoral immunity, the circulating antibody, declines or wanes over time. In fact, that happens relatively quickly, believe it or not, in that 3+ month time period. your cellular immunity or T cell immunity is better maintained over time, but it drops over time too. So the idea of getting these boosters, much like we do with flu vaccine every year, is going to be important. We're never going to be free, as far as anybody can see. We're never going to be free of COVID. So this becomes at least an annual booster, much like flu.
Jean has a question that we get quite a bit. So if you can help us lay people break this down again. Jean writes, how should someone coordinate and schedule flu vaccine, RSV vaccine, and the new COVID monovalent vaccine? That's a great question.
Yeah, it's a great question. And we got it a little earlier, so one of you want to kind of take a swing at that one?
Yeah, I mean, I think certainly I'll start and then look to Dr. Poland. But I know, last year you could receive both the COVID booster and the influenza vaccine together.
On the same day, which I believe I did on this program.
Yeah, absolutely.
My cool tidy-whitey
Absolutely.
tank top. Yeah.
I don't know about the recommendation yet just for the RSV vaccine. I wouldn't believe that there's any significant issues. I'll look to Dr. Poland to help answer that. But as we addressed earlier in the show, because of the current availability now of some of these vaccines, i.e. right now in some places RSV vaccine is available, go ahead and get that. Once influenza vaccine is available, probably get that at that point in time as well. But then we are still awaiting for the rollout of the booster for COVID-19. So likely this year, there is a good chance you may receive these vaccines at different times. But if you are someplace and you have that opportunity to vaccinate and they have those vaccines, I would recommend to get them at that point as well.
Maria has a question.
Go ahead.
I just absolutely agree. The best thing to do is to get your vaccine and to get them when they're available. Huck is right in that the early clinical studies have not shown any issues with receiving more than one vaccine at a time. One tiny proviso. I don't want to overplay it. It's just one observation. In the GSK study, the 2 cases of acute disseminated encephalomyelitis, sort of a Guillain-Barré-like variant, happened in the 2 people who got RSV and flu vaccine together. It's very likely coincidence, but it's something, as was mentioned at the top of the hour, that they'll be looking at in these so-called phase 4 studies. So it's just helpful right now because of the way the vaccines are being rolled out. Go get your RSV vaccine now. It does not wane over a 2-year time period. Then next available will be your flu vaccine, then your COVID, or get your flu and COVID together.
Okay. Maria has a question. Maria would like to know, what do you recommend when it comes to masking and a rise in cases?
Masking and a rise in cases. I don't think we're going to call for public masking yet. We're actually going to have a chief medical officer call, I think, next week about that for the metropolitan-wide hospitals, because we're all seeing a slight uptick, but the numbers are still incredibly low. So I know from a hospital standpoint, we're not contemplating everybody has to be on a mask again. Now, could that happen? You bet, if the numbers keep going up, and especially if we start seeing disease transmission within our staff and things of that nature. But our absenteeism hasn't really changed yet, something we keep a close eye on every day. On the other hand, if you have an immunocompromised illness, if you've had a lung transplant, for example, I'm talking to all my lung transplant patients out there, put your mask on when you're going into crowded places.
I think that's it. Understand your situation, and it is always okay to wear a mask. Wearing masks does help reduce your chance of infection. That is shown in the literature. So you actually do get a protection from masking, even if other people around you are not.
It's important to emphasize that because there's been a lot of controversy. I hope that, like many Asian nations, that during respiratory viral season, we'll take up the habit of wearing masks in crowded indoor areas. But let me just stress that when we were masking during especially the first 2 years of the pandemic, we didn't see any influenza. We didn't see any RSV. They were gone. Influenza B Yamagata still has disappeared as a result of that. So no question that proper masking is effective.
Joellen has a question. She writes, I participate in an indoor exercise class 3 times a week. I'm 75 and most of the people in the class are older than 65. Could you please discuss the whole indoor gym, etc. risk?
You know, Haka, I'm still going to the gym, and I'd still go to the gym. Yeah. So I don't think I'm going to curtail that yet.
Yeah, I mean, I think there is risk. We have to understand there is risk, and that is shown very well in the literature as well. Again, understanding the situation that you're in. How many people are going to be there? How is that space enclosed? Is there a lot of good ventilation? Things like that. So I think there is an increased risk for those types of things, but understanding that and understanding those situations that you're put into is vitally important.
You know, I agree. If the culture is, if you're symptomatic with illness, don't come. Have at least 6 air exchanges in that indoor space. And it's not terribly expensive to have an air purifier in a room like that. That's also helpful.
Yeah, I think those 6 air exchanges an hour do make a big difference. Creates a little negative airflow in a room. And that's why we don't wear masks here in the studio. We have 8 exchanges an hour. And if you sit here, you actually feel the breeze.
Yeah.
Angela has a question, again, about boosters and vaccines. Angela wants clarification. Should we get the booster that's available right now, or should we wait for the new one?
Dr. Poland, thoughts?
Yeah, we could vary a little bit on this. Here would be my recommendation. If you are very high risk, for example, if you're one of Dr. Steitz's solid organ transplant patients and you've not gotten a bivalent booster, go get a bivalent booster. If you're otherwise healthy and otherwise up to date on your immunizations, I would wait, because in that case, if you got the bivalent booster now, for example, if I got a bivalent booster right now, I would have to wait 3+ to 4 months before getting that new monovalent booster. Well, that's into almost December timeframe. So given how low the risk is right now, given that I'm otherwise immunized, I feel safe in waiting until that booster comes. But again, if you've got a lot of underlying illness, disease, immunocompromised, I would feel differently.
Angela has a follow-up to that. She wants to know if the booster will cover the new EG5 variant that we've been talking about.
I guess that's the big question.
It really is the big question. We don't have research on that yet, obviously, because it hasn't been released. Let me try to sketch it out. Way back here is the Omicron variant. There was a family called the XB1.5 family, all the way to XB1.51. That's what the vaccine is being made against. There was another family coming from Omicron that was XB1.9.1, the so-called Hyperion family. And that's what the EG5 and EG5.1 variant are coming from. So because they both come from the Omicron lineage, we expect that they'll be very effective against severe disease, maybe slightly less effective against mild symptomatic disease. We don't know yet, but I do expect that it will still be effective.
We have an email question from Jason. Jason has an excellent question about COVID surveillance and case counts. He asks, could there possibly be a much higher level of viral transmission than is currently perceived because there's no longer any accurate monitoring of case counts?
You know, I think the answer to that is yes, and there are a couple of reasons. A, we know the wastewater testing has shown an increase, significant increase in COVID. B, hospitals aren't quite as good at reporting their COVID data now. You know, we report it, really we're looking at it on a weekly basis because it takes a lot of work actually to figure out which patients have COVID and which patients here were from COVID, as opposed to they're here and they also happen to test positive for COVID, but they're here for, like, say, a motor vehicle accident, et cetera. This is a fairly time-intensive work. So we've backed that off because our COVID counts were so low. So I think we say, well, we'll rely on hospitalizations. Hospitalizations data may not be as clean as it was a year ago, and clearly public reported data is not clean because there's so many home cases being diagnosed now. So I think it's just harder to know. And but what I can tell you this is we don't have a lot of COVID patients in beds because that we would feel. So I don't know, Dr. Poland, any other thoughts that you would have?
Yeah, I agree. What we do see is sort of tip of the iceberg and the more complicated or symptomatic cases. But in terms of circulation of the virus, it's very hard to know. One interesting study looked at the 5,000 or so Walgreens outlets around the U.S., and they showed a profound increase in the number of positive tests that they were seeing. Again, that could be perturbed by relatively small numbers, but I would agree that there's very likely more virus circulating than what we understand from publicly reported databases.
What are you feeling too? I mean, you're on consults for COVID, et cetera.
Yeah, I think that's absolutely right. I think as we have kind of gotten now into the later parts of the summer, moving into the fall, I think overall in the community, the viral circulation has increased a little bit compared to where it was, say, a couple of months ago, but it is definitely hard to tell. So we have to use those other indicators like wastewater testing, like those areas where we can get some data like Walgreens or the hospitals, but then anecdotally too. So I think we all do believe that there is probably increased circulation of the virus going on right now in the community, but it is very hard to get those concrete numbers.
Yeah, when you start watching wastewater testing go up, this is my own personal hypothesis. There's no scientific validity underneath this whatsoever. It's kind of like watching Star Trek. But it got so hot so fast, you wonder if people kind of went inside. It's almost like it got too cold so fast. It just got really hot so fast. Because the wastewater testing's been up for over a month.
Yeah.
I have one more question we're going to squeeze in from Jean. Jean wants to know, and this is back to the order in which we get our vaccines. Jean asks, is there any problem taking these vaccines with the shingles vaccine?
Oh, another great question, Dr. Poland. What are your thoughts?
No, I don't know of any issue with doing that. The one thing that she would probably notice is these vaccines cause a beneficial immune reaction. But that beneficial immune reaction can make you feel fluish. It can make you feel achy and tired, maybe even a low-grade fever. Shingles vaccine is particularly known for that, at least for the first dose. So if you were to do all of those together, I would probably do it on a Friday.
Yeah, and have some Tylenol ready.
Yeah.
All right. This has been an outstanding discussion, and I'm grateful for our guest. Dr. Poland, I'm so grateful for you being here on your birthday. Yeah. Tell your family thank you, because as I understand it, you're not in your normal office. The backdrop's a little different. I think you're in North Dakota, is that right?
South Dakota, visiting my 2-year-old grandson and my brand new 2-month-old grandson.
Oh, that is awesome. I remember you saying before you couldn't go see some of your grandchildren or your daughter, I think, because of COVID. You didn't want to bring disease, and so now you're out there being able to see these folks. That's great.
Yeah.
All right. Well, final thoughts from you, sir, and happy birthday.
I think the thing that I would try to say to people is ignore social media. Don't get your medical information from sources like that. Get it from high quality medical centers. Whether you go to University of Kansas, any medical center's website, you're going to see the same information there. So, be, as we say, be wise, immunize. What that really is saying is you want to protect yourself against being hospitalized. Something people don't often think about is you want to protect yourself, if you're an older person, from losing your independence. This has been well documented that people develop severe respiratory viral illnesses and they end up not being independent again. So this is a really important proactive measure you can take to protect your health. I often tell people, look, if this wasn't important, this is not what I would spend my adult career on. If this wasn't important, we wouldn't have all of my family and all of the physicians at Mayo Clinic immunized, and same at University of Kansas. This is an important proactive measure to protect your quality of life and your well-being.
Perfectly said. Be wise, immunize. I love it. Hawk?
Yeah, I'd like to piggyback on that. So first of all, thank you, Dr. Poland. Again, one of our favorite guests here, and we certainly know you are our viewers' favorite guest for helping get out that information and combat that disinformation, just like you said on social media. Other sites of disinformation, we know that is a big business. And we are here to help inform you, to keep you protected. We know, number one, these vaccines, what do? They don't help prevent against infection. They help prevent against hospitalization, just as you heard Dr. Poland say. Hospitalization and severe disease and keeping your independence. Those are the main goals of these vaccines. The other thing is they are very safe and efficacious, and we will continue to be transparent with you, always commenting and reporting on the effects of the vaccines, but then any of those side effects as well, just to continue to be transparent and give you the accurate information so that you can make those best informed decisions for yourself and your loved ones.
You know, here's what I would say. First of all, thanks to you guys both, and thanks to all of you for the great work you do. Science does not give us all the answers. What science does is it helps us get answers. The problem with the internet and internet science, or what I like to call it rumor reporters, is that there is no science. So even though science may not have all the answers, it's an unending quest to try and get those answers as soon and as rapidly as possible to make a difference in all of your lives. Rumor reporters are just making it up. Hey, we're going to be back tomorrow with another edition of the Morning Medical Update. Thanks again to all our guests and to our audience. Remember, faith, hope, science.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcasts. Now, everywhere podcasts are available.